Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going. Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going.
Karibu Tophill Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies. With a capacity of over 70 operational ward beds, over 30 specialists and consulting doctors, Tophill Hospital is a modern level 5 facility equipped with 12 state-of-the-art ICU HDU beds and 2 modern HEPA-filtered theaters with laminar airflow. Our aim is to provide comprehensive quality services at an affordable cost to the community, which includes but not limited to neurosurgery, radiology and diagnostics, MRI, CT scan, X-ray, ultrasound, endoscopy, ECG, EEG, pediatric cardiology, physiotherapy, orthopedics and trauma, pharmacy, laboratory, theater, ICU and HDU, obstetrics and gynecology, general surgery, maternity, psychology, psychiatry, comprehensive wellness checkup, dialysis and urology, oncology, dental care, ENT surgery, nutrition and dietetics. For ease of movement and transfer of patients, the hospital has 2 modern critical care ambulances equipped with ICU facilities and available 24 hours. Tophill Hospital is located in a serene environment away from noise and has a cafeteria with fresh, nutritious foods, not forgetting ample parking for all clients. Tophill Hospital is NHIF accredited and accepts medical covers from a number of insurance companies. If you're looking for the best customer care and patient experience and to be attended within the minimum waiting time possible, reach us through the website www.tophillhospital.com or call 0782 121214, or you can also call 0782 900090. You can also email us through info@tophillhospital.com.
Good morning to you. Good morning to you. Indeed, this is the Morning Glory Show. My name is MC Kalia, the Healthy, Wealthy, Wise Wednesday. Of course, being 15th day of February 2023. One day after Valentine's. By the way, happy Valentine's. Of course, you can see the background. We still have some love with us. So kama mtu akukwambia happy Valentine's jana, I'm so happy to wish you a happy Valentine. Kama your personal disappear jana, we can try again next year. Nonetheless, we are here to learn about health. We are here to improve our health education. And with us in studio is Dr. Kevin Ruto. He's been here before from Tophill Hospital to help us understand non-communicable diseases. People also told me they're called lifestyle diseases. And so today we'll be talking about ulcers, we'll talk about hypertension and diabetes. But then before we go there, allow me to remind you that you are tuned into the best morning show. You tuned into the most comprehensive morning show, the Morning Glory Show, coming live from Dawi Afrique Photography. Dawi Afrique Photography situated in Eldoret at Basement A. So anytime you're in Eldoret or within this region and you need those nice photos, consider working with Dawi Afrique Photography. Right away, allow me to give a chance to Daktari to say hi to you and talk a little bit about today's topic. Karibu Daktari.
Thank you very much, MC. Morning once again, and welcome to our Morning Glory Show. That is the Healthy, Wealthy, Wise Morning Glory Show. My name is Dr. Kevin Ruto. I've been here before, and to those who didn't feel loved yesterday, we want to start your day with so much love, mapenzi, as we even proceed for the rest of the show. So feel loved as we stay healthy, wealthy, and wise.
Daktari amesema feel loved. We'll talk about that some other time. Kumbe tutamuita pia editions. We'll call you on Thursday. It's called the Social Square. You tell us a little bit about how things go around the hospital there. Kama kuna kuwa na mapenzi huko. Anyway, now if you're already tuned in, let me know where you tuned in from. If you are already in there, of course, help me share the broadcast. Let's have as many friends as possible watching this particular broadcast. Of course, this is where the most important conversations go down. And don't let your friends miss such important conversations. So as we share the love, let's also share some information. Daktari, today we are talking about non-communicable diseases. Okay, the topic was actually lifestyle diseases. Then there's a friend of yours who told me, okay, just call it non-communicable diseases. So maybe tell us a little bit about that. We'll be talking about ulcers, diabetes, and hypertension. Of course, we'll start with hypertension. Maybe set the pace for us. What does it mean when you say non-communicable diseases?
Okay, what we mean when you say non-communicable diseases, basically we mean these are diseases that are not transmissible from one person to the other. Unlike all other communicable diseases which are caused by infectious processes, bacteria, viruses, and the rest, for the non-communicable diseases, these are diseases that you do not transmit from one person to the other. When you have it, it is for you. Okay. So another thing that has been, another name that has been given to these diseases is lifestyle diseases, because a majority of them basically have usually been as a resultant of the way we live, the food we eat, and a majority of the things that we do on a day-to-day life that some can be adjusted. So that is why we would call them lifestyle diseases.
Okay, thank you so much for that. And I was looking at the statistics, of course, for the diseases we're talking about, and you realize that so a very good percentage of Kenyans and even people worldwide suffer from these conditions and these diseases. And so looking at hypertension, of course, what exactly is hypertension?
Now, yes, MC Kalia, you just mentioned right. The statistics have currently been on the rise for the lifestyle diseases, that is hypertension, diabetes, and ulcers. But a majority of them really, they have been contributed majorly by the fact that we've really changed the kind of way we live. A majority of us, the level of activity has really gone down. We are seated in offices for a very long time, not staying healthy, not exercising much. So that is the reason as to why they have been on the rise. Okay, so these initially were diseases that we used to associate with the whites and the other European countries, but now they have come to us and they're on the rise. So just to start us off, we are going to be talking about hypertension. And just to introduce what hypertension, or what other layman's call high blood pressure. Hypertension is, these are blood pressure recordings, usually above a level of 120, that is the systolic, over 80. Okay, and this usually is when you have a recording of more 3 times in 3 different setups, meaning once you have a recording of more than 120 or over 80 of your blood pressure at this point in time, and maybe after next 1 hour in different setups, you still record a consistently higher blood pressure than that is when we say now that you have what? Hypertension. So hypertension, as we proceed, is classified. So just as I mentioned, hypertension, blood pressure, your normal blood pressure is supposed to be 120 all over 80, okay, or less. But then whenever you have a systolic blood pressure, when I say a systolic blood pressure is blood pressure, the numerator being above 120 to around 139, with a numerator of around 80 to 89, okay, that is when now you have what you call, you are at the pre-hypertensive phase, meaning that you can be toppling over to what? To hypertension at some point in time. Now, any recording above, a systolic recording above 140 to 159 with a systolic of 90, okay, 90 to 100 to 99 actually, you are doing stage 1 of hypertension. So you are an hypertensive patient. Yeah.
We go there, Daktari. You've talked about the numerator and the denominator. Of course, we've seen them severally. Maybe in just as a minute, what exactly does the numerator mean and what does the denominator mean? Maybe for the benefit of those of us who really don't understand what those things mean.
Exactly. So just as I mentioned initially, I said systolic and diastolic. Then I noticed that it might be hard for that even to be understandable further. That is why I chose to call it the numerator. When you say systolic, the heart contracts and relaxes. Okay? So as your heart contracts, it gives some pressure at the vessels. Okay? During that contraction, the blood pressure that we record during that heart contraction is the numerator. Okay, what we call systolic blood pressure, and that is why it's on the higher side. The numerator is the blood pressure recording that we get when you're having what? The heart relaxation during the diastolic. Diastolic means as the heart relaxes. That is why it is usually on the lower side. So that is basically what the numerator and the denominator in the blood pressure recording mean.
Then now take us to now what the figures now, maybe when it's normal, maybe now allow just me to call the denominator the numerator because I may end up chewing my tongue, so it would be right that we just use the denominator. So maybe what are okay, of course you've mentioned it before, but then once again take us through now how the numerator would look like in a normal person, then how it would look like now as you continue. Of course it would be a repetition of what you've just said, but then I think it would be no more understandable to the viewer. All
right. Thank you. So, just as I mentioned, a normal blood pressure is supposed to be having a numerator of 120 with a denominator of 80 or less for the two. That is a normal blood pressure recording. Okay. So, systole of 120 and diastole of 80. That is the normal blood pressure. And not only in one setup, because at times we have what we call white lab coat hypertension. You come to hospital, you see me in a white lab coat, and now you have this tension. So we might get one recording of slightly higher than that, but it does not mean that you are hypertensive. It just means that there is just that anxiety. So it has to be in different setups, okay? So that is the normal value.
Okay, so of course I've seen we've talked about anxiety, and that would be that was going to be my next question. When you say different setups, maybe does it mean maybe if for you to be certain, then you may need to have it recorded maybe in a hospital setting, then at some point at home or somewhere like that, before you conclude that somebody has hypertension? What does it exactly mean?
What we usually say is that 3 recordings more than 30 minutes apart. Okay. So that is what we are calling.
So kama mtu alikuwa anxious ya kwanza hizi kuwa anxious sana ya pili.
You cannot be anxious after 30 minutes. The next 1 hour, the next 2 hours continuously. At least you will relax at some point. So we'll see the trend.
So maybe what are the factors that affect the blood pressure of a human being? Before maybe we even talk about now it being a condition, what are the normal factors that affect our blood pressure?
So among the risk factors that have been associated with the hypertension or high blood pressure, we have those factors that we've classified as modifiable factors and those factors that we've classified as non-modifiable factors. I'll start with the non-modifiable factors. When I say non-modifiable factors, these are factors that you cannot change. They are there and they are constant. One of them being a family history of hypertension. Having history of hypertension in your family put you at a risk of developing hypertension at some point in life. That you cannot change. You cannot change your family. You are from there and that remains constant. Number two of the non-modifiable factors is age. Majority of hypertensive patients are usually the elderly. The more you grow, there are some changes that occur in your blood vessels and all that. And hypertension can set in. You cannot change that. You will grow and at some point hypertension can catch up with you. Another one is your race, so ethnicity. A majority of the cases, especially the Caucasians and the whites, a majority of them have high blood pressure. So they cannot change that. Okay. Then another non-modifiable factor is sex. It's been shown that actually it's the men. I think men are more at risk of getting hypertension compared with the women for one reason or the other. That still you cannot change. So those are some of the non-modifiable factors that we cannot be able to change. But then there are those modifiable factors, those that we can be able to adjust through lifestyle. One of these major factors is alcohol use. Alcohol and cigarette use have been shown to be a major contributor of hypertension. Number two is obesity, watching your weight. Okay, excessive weight is a major risk factor for hypertension. Sedentary lifestyle. Sedentary lifestyle meaning that your work is just to eat, to sleep, sit in office, no activity, no much activity that can burn down your weight. Then excessive salt intake are some of the other modifiable factors for risk factors for hypertension, just to mention but a few among others.
Okay, if you already tuned in, of course, this is the Morning Glory Show. You tuned into the most comprehensive talk show online today. My name is MC Kalia, and with us in studio is Dr. Kevin from Tophill Hospital, helping us understand some of the non-communicable diseases. Right now, talking about hypertension. I can see some of you already inside the broadcast. Ambassador Alfred Sargent, all the way from Perth, Australia, saying he's tuned in. Gladys Chepkirui, good morning to you. Good morning to you, Gladys. There is Gogo Small saying good morning, team Morning Glory. Good morning to you. Mildred Sum, thank you so much for making time to be with us. Kims Levin saying good morning to you. Of course, the more if you're already in, make sure you like the broadcast, because the more you click that like button, then the better, because I can see that you're actually watching. Then also help me share the broadcast. Let's have it reach to as many people as possible, because as I usually say, the most important conversations happen on the Morning Glory Show. Daktari, you've mentioned about non-modifiable, modifiable, the ones that we can modify, the things that we can change. You've talked about weight, you've talked about salt, you've talked about the issue of sedentary lifestyle. The last time I had that term was ilikuwa high school. You guys cannot have sedentary life in this school. You must work. We had one teacher who liked using that one, and to come with a sedentary, so at least the word is coming back. So actually now when you talk about the ones we can modify, maybe in terms of the records you get of patients coming into the hospital, in comparison, do we have more patients coming because of the things they can modify, or is it more patients coming with the things they can do nothing about? When you compare the two causes of hypertension from where you sit as a doctor receiving patients, which one maybe has more prevalence?
Now, there seems to be an interplay between modifiable and unmodifiable factors. Okay, so we cannot really be able to give a clear cut as to whether it's due to the sedentary lifestyle or the non-modifiable factors. Now, our major focus usually, as we try to educate people, is for them to understand that there are those things that you cannot change. And because there are those things that you cannot change, let's focus on the things that you can be able to change so that we do not get there. If you have a family history, we tell you at least focus on those things that you can change so that you do not topple over to you cannot topple over to hypertension. So yeah, a majority of them of course will be those patients you can attribute to the modifiable factors, okay, because of that interplay, the non-modifiable leading you to the modifiable, okay. So yeah, majority of the cases are due to modifiable risk factors.
Daktari, does hypertension have symptoms and all that? How do I know I have hypertension?
So hypertension, yes, they call it a silent killer. Okay, they call it a silent killer because its symptoms are not as obvious as any other symptoms. Maybe if you can just allow me a bit to go back to the classification. I think I reached somewhere. Stage 1, the pre-hypertensive phase, the stage 1 hypertension, stage 2 hypertension, then what we call overt hypertension. This is hypertension by the time you get to stage 2. Stage 2 is when you are at around a systolic blood pressure of around almost 160, with a diastolic more than 100 to around 110. That is really significantly high blood pressure. So you start getting these feelings of on and off headaches. You get this generalized body malaise. You just feel tired, okay? Then at times you feel what? Easy fatigability. Just the slightest activity you try to engage in, you feel tired so easily. Then it also comes with at times bilateral. Bilateral, I mean lower limb, both legs swelling. Eh? So those are some of the symptoms that they come with. It's not so painful. It's not so, but now those are the things that you start feeling. Okay, so some people tend to ignore this because they at times do not affect your activity so much. But then by the time you go above now the 160, when you reach at 180 mark of the systolic blood pressure, over 110, those are some of the things that we call, in case you haven't presented with other things that I'm going to talk about, we call that an hypertensive urgency. An urgency is in case you set foot in hospital with such a blood pressure, that is definitely an admission, because walking around with such blood pressure is a pending emergency. Things can happen at any point. And when I say things can happen is because, one, some of these things that happen when you have a blood pressure of more than 180 and 110. One is stroke, which we've seen in a majority of our patients, especially the elderly. A patient has been going around, just the activity, going to watch their cows. You want to say hi to your grandmother, MC. She's so happy, has a blood pressure of...
Alafu kidogo anaenda.
Then kidogo. And you're like, what's up? It's because of that. Anxiety. Happiness, yes, shoots your blood pressure, and you get those. So a stroke is one of them. Another thing is what? Heart attacks. Heart attacks are some of the major complications of what? Hypertension. Okay, so those are towards the end. Now, whenever you present with such symptoms, that is now what we call an hypertensive emergency. So there's an urgency. An urgency is you have a blood pressure more than 180 or 110 with just these mild symptoms and no end organ damage is an urgency. But by the time you present with an end organ damage you mean either you a stroke, either your heart is compromised, either your kidneys are compromised. That now becomes an hypertensive emergency. Yes.
Okay, of course this is the Morning Glory Show coming live from Dawi Afrique Photography. Remember that Dawi Afrique Photography is a production house based in Eldoret, and anytime you need anything that goes into production, not only in Eldoret but then in the whole region, consider working with the Dawi Afrique Photography. We are here to make sure that you get a nice experience in front of the camera and nice memories at the end of it all. Daktari, now you've talked about the complications that come with hypertension and the level at which it may come. Looking at all that, then that means that maybe hypertension then is a lead to bigger problems, right?
Exactly.
Okay. Now, when we talk about when we talk about prevalence, maybe in young people and old people, you've said that maybe it's majorly in old people. Okay. I'm doing this for the purpose of my viewer who's not maybe been following up to where we are at the moment. Now, from where you sit, you've talked about the issues of age and all that. Let's talk about now. If we were to avoid all this, especially talking about the factors that you've said we can control, what are some of these things that we can do to make sure that we reduce the number of people having hypertension? If I suspect that maybe I have something within my lineage that we have a family history of hypertension, what are some of the things that I may do to reduce the probability of me contracting hypertension at the end of it all?
So, one, we talked of what hypertension is.
Yeah.
Then we've classified what the different meaning of hypertension. We have also types of hypertension, okay, which we call one being the primary hypertension, the essential hypertension that is usually associated with the elderly, okay. But there are other kinds of hypertension actually, or high blood pressure, which another one is secondary hypertension. When you say secondary hypertension, if today MC Kalia, at your age, sweet 18 as it looks, and you come in with hypertension.
You need to say that again. Yesterday was Valentine. Hey guys, Dr. has prescribed me a sweet 18. This is a prescription.
So if you come in with hypertension with hypertension at your age, I will have to look at that from a different angle, because basically at your age you're hustling. It's now 6 and you're already up and about, so you do not really have a good reason as you should be having hypertension at this point in time. So probably we try to look at secondary causes of hypertension, which some of them could be some malignancies, what we call pheochromocytoma. Okay. Other things is the thyroid. When you have a problem with your thyroid, it can lead you to triple 2 hypertension. Kidneys. When you have a kidney failure for one reason or the other, it can give you hypertension. What we call renal artery stenosis. Renal artery stenosis are the blood vessels that supply your kidneys. When they are stenosed, when they are narrowed, you get hypertension. So we tend to look for those things among the young. Okay. So that is secondary hypertension. Usually they are not contributed by the modifiable factors. Now, coming back to your question on, in case I have a family history, what are the things that that I can do to avoid this? So, majorly when you are controlling primary hypertension, okay, primary hypertension, we focus on the modifiable factors. Alcohol intake is usually one thing that we focus. You are an alcoholic, we say you have to stop.
You have to stop.
You have to stop. Mm-hmm. Not even reduce. You have to stop. Mm-hmm. Okay, because it ends up depositing so much impurities in your liver, in your blood vessels. That is why it leads you to that. Another thing is smoking. You stop that. Okay. Then, of course, watching your weight. We have something called the body mass index. The body mass index, you calculate the body mass index based on your height. Okay. Your height, you divide by what? Your weight, you divide by your height. That is in meters squared. So in case you want to know what your body mass index is, you just take your body weight in kgs. Okay. Then you divide by the square of what? Of your height in meters. Okay. This figure is supposed to fall between 18.5 to at least around 24.9. Okay. By the time you reach 25 and you find yourself you are at a body mass index of around 29, you are overweight. Okay. Anything above 30, I don't know whether anything above 30, that is now, you're obese. Okay? You are obese. Okay? Then we have those people who, they are overtly obese. Those people who are very huge. You know, whenever you are that huge, it means you can basically do nothing. You can basically not engage in so much activity. So you will tend to be lying around a majority of the time. That can topple you to hypertension. So that is one thing you need to work on. Work on your weight so that it can your body mass index can fall between 18.5 to around 24.9. Okay. Then of course the other thing that can be modified was your diet. We need to modify our diet to you decrease your not only protein but your carbohydrate intake. Okay, we've noticed that so many people currently, and the reason as to why initially the prevalence of hypertension and diabetes was more in the whites and all that was because of processed foods. You take bread in the morning, you take chapati, so much of gluten, you take so much of fries, chips, all that fat. Okay, you do have pizzas, burgers, all that. That is what you're feeding your body. The junk foods, which unfortunately it's become a trend. So that is a tickling bomb. It's a tickling bomb which can lead you to hypertension. So those are just to mention some of the few things that we can adjust. Your diet and your salt intake should also be on the lower side. Okay.
Okay, I've had salt so many times being mentioned. I think you can give some special attention to salt and stress. How related is that to hypertension?
Now, excessive salt intake, usually, they say where salt goes, majority of the time water goes, right? Because of the basic science that you learned in high school, osmosis. You have so much salt, so you take in so much salt, you retain
water
so
is
much
pulled towards.
Yes, because of the so once you retain so much water, what happens in response? You're going to the vessels are going to be having a higher volume of diluent solvent. So your blood pressure will be on the higher side. So by controlling your salt intake, then you can be able to reduce more water retention in your body and therefore be able to control your salt.
Okay, and let's talk about stress before maybe we move to the next condition. Stress and hypertension, is it a myth or does it exist?
It does exist. It does exist because but a direct link as to what you call pathophysiology is not direct. What stress does, when already you have an underlying risk factor to hypertension, okay, you are obese and all that, then you add some stress, you are always anxious. Anxiety raises your heart rate. Okay, so always anxious, always stressed, always thinking. You are not sleeping well, so you do not have enough rest. You can hardly engage in constructive activity. When that happens, then blood pressure follows suit. And worst of all is when you have already existent blood pressure, then you add on stress onto it. So you now topple over to what? The urgency and what? Emergency. So you topple over to stroke, then you topple over to what? Heart attack. Because of that, when already you have an existent blood pressure.
But then there is no direct link.
There is no direct link as to I'm stressed now, because stress is a day-to-day encounter. So
there's no way an instant maybe an instant case of maybe somebody was stressed up and they had high blood pressure and died.
No.
Okay.
No. Your body has a mechanism to control your blood pressure. Okay. Intrinsic mechanisms. So you cannot be having a blood pressure of 120 all over 80. Then you get stressed. Maybe your dog was hit by a car somewhere. Then it goes all the way from 120 to 180. Then you have a stroke. No. that is not. It has its own intrinsic mechanisms. Okay, so, and that is why we say hypertension. We say hypertension. We have to take back is 3 different recordings consistent over time. Okay. Yes.
Okay, somebody here says Daktari should mention something about also the opposite of high blood pressure and heart disease. Okay, we may not have sorted it in to talk about that, but then now that it has come up, the issue of would you now call it hypo? I don't know. Would you call it hypertension or something? Or I'll be saying something else. Anyway, somebody says the opposite of hypertension when the pressure now is low, and heart disease. Maybe is there a relationship between all that?
The opposite of hypertension is hypotension, which hypotension has its own different causes.
So it is something else that maybe we may need to talk about it another time.
Yeah, it is. A majority of the times, hypotension is we usually attribute it to an underlying disease process. You've been vomiting and diarrheaing because you're taken in for Valentine's and you took something that didn't go well. So you've just been losing water. So you topple to what? To hypotension. Other things, you've been diseased, you haven't been eating well and all that. You topple to hypertension, you haven't been taking water. Hypotension. So hypotension basically, or you've been on some medications that cause what? That lower blood pressure significantly. So that is why we do not focus, because usually with hypotension, those are diseases.
So maybe, and then also maybe it could be within a very short time
exactly
when you talk about drugs and all that.
Exactly.
Okay, thank you, Chepto. Maybe that would be answered better in a future segment. Maybe we'd have some time to talk about hypertension and the conditions that come with it. But then as we move, then unless there's something else Daktari would want to talk about, maybe to caution people about hypertension, then I would want to move to the next condition, maybe diabetes. Yeah.
So I think we've mentioned the necessary things that could be associated with hypertension. What I would just want to say is that for those factors that we can change, let's focus on addressing them. We say, for us, as far as hypertension is concerned, and actually diabetes, we say if you can engage in at least 30 minutes of vigorous activity. Vigorous activity, it means some activity that can raise your heart better and that can keep you sweating for at least 30 minutes. 3 to 5 times in a week, daily. You stand a very high chance of controlling your hypertension.
Okay, I'll be hiring out my bicycle. I have a very nice bicycle, so next time you have a patient, send them to me. I need to make some small money. Anyway, if you tuned in, this is the Morning Glory Show. It is the most comprehensive talk show online today. With us is Dr. Kevin Ruto from Tophill Hospital, helping us understand non-communicable diseases. We've just discussed hypertension. Of course, if you missed it, the link remains on the page. You can always go back and review it. It is also available always on the page, so anytime you'd want to watch it, then also you'll be able to watch it. And starting today, of course, we'll be having reruns of this show in the evening, so whatever we've just done will also run live in the evening starting today. Now moving on to diabetes, it is also another I would say menace. It is I think I know of almost so many people who have diabetes. First of all, I don't know if it's just that I'm now interested in health, that I'm now doing a show that is health related, or is it something that has always been there? Why do you have so many people suffering from diabetes, and what exactly is diabetes, Daktari?
We call diabetes and hypertension, actually we've actually begun calling them spouses, because they have really tend to work hand in hand. A majority of our diabetes patients, we've noticed them to be having hypertension. High blood pressure. But that reason, of course, is under the pathophysiology when you look back as to what diabetes does to your blood vessels and all that. So moving on swiftly to diabetes. Diabetes basically is it's high blood sugar, okay, in the body. Just like in hypertension, the body has intrinsic regulatory mechanisms for which it can regulate your blood sugar levels within a specific range. Okay, and the major organ of your body that does this is the pancreas. The pancreas secretes what we call insulin, which is a regulator of your blood sugar, and glucagon, which is also an equal regulator. What insulin does, it brings your blood sugar down, and when it is low, glucagon, which is also secreted by the pancreas, raises it up a bit so that you can fall within a particular range. Okay, so diabetes, the normal blood pressure, the normal blood sugars, we have what you call random blood sugar recording. A random blood sugar recording, you've had your breakfast or lunch, so I just find you and I want to test your blood sugar. Ideally, a random blood sugar recording that we do randomly is supposed to fall between at least 3.1 to around 7.8. It's not supposed to go beyond that. Okay, some people say from around 2.8 to around 6.8, but for me, I put it at 3.1 to 6.8 actually. Okay, so that is normal for a random what? A random blood sugar. It is actually 3.1 to 7.1. Okay, but then for a fasting blood sugar means this is a blood sugar recording that we get in the morning. You ate in the night, you've been asleep the whole. So the first thing I do in the morning, just before you take anything, is a fasting blood sugar. Okay, so that one now is the one that is supposed to be, it's slightly low, around 2.8 to around 6.8. The other one was 7.1. So it's not supposed to go beyond there. So that is a normal range. That is a normal range. But then any recording above 7.1 for a random blood sugar to around 11.1, you are a pre-diabetic patient. A pre-diabetic patient, it means that there is impending diabetes. Okay, but any blood sugar recording, a random blood sugar recording above 11.1 going up, then you are a diabetic patient. So that is basically what diabetes. Any random blood sugar recording above 11.1 is diabetes.
Okay, and let's talk about prevalence maybe before we come to what really causes diabetes. How is it? Is it more in children? Is it more in old people? Is it something that cuts across?
Good. Now, we have types of diabetes. Diabetes type 1, diabetes type 2, and other kinds of diabetes. Gestational diabetes, which is associated with pregnant women, and other kinds of diabetes. Okay, so diabetes, the most common kind of diabetes is diabetes type 2. That is the most prevalent. Diabetes type 2 is what we call insulin independent kind of diabetes. Okay, this is usually more prevalent among the elderly. That is one, and among those families with history, it is the most prevalent. But for diabetes type 1, what we call the juvenile onset diabetes is the one that is more prevalent among what? The young. Okay, the young. So up to around the ages, the adult ages around 35. Okay, youthful age, adolescents. Those are diabetes type 1, the insulin dependent diabetes. Yes.
Okay, maybe what do you mean when you say type 1, type 2, and when you say maybe insulin dependent and insulin, what does it exactly mean? Maybe take us through the types.
Now, when I say insulin dependent, so there are two things involved as far as diabetes is concerned. One, you can either be secreting too little of insulin, okay, so that you cannot be able to regulate your blood pressure, or
blood sugars,
your blood sugars, or you could be secreting enough insulin, but your cells, what you call receptors for insulin, are not responsive to the insulin that you're producing. That is now what you call insulin independent kind of diabetes. When you say insulin independent, it means that yes, you have enough insulin, but now the insulin is not responding to the receptors. Okay, so that is one. Now let's go back. For diabetes type 1, which is more prevalent, among the young
people.
yes, the majority of them are not producing enough insulin. Okay, they do not produce enough insulin. So what do you give? We give insulin. A majority of them we put them on an injection of insulin so that they can regulate their sugars. So that because they are not producing enough, we elevate it. So they are more of insulin dependent diabetes. It's because they have less of insulin, and that is why
They may not be able to control the blood sugar.
able to control their blood sugars. But now for diabetes type 2, which is insulin dependent, you might be producing enough insulin, but the receptors now have become unresponsive over time. So yeah, you have enough insulin but unresponsive. So it is insulin independent, because yes, you have the insulin but you are still not be able to regulate your blood sugars. So that is basically what I mean by the two.
Okay, this is the Morning Glory Show, coming live from Dawi Afrique Photography. My name is MC Kalia, and with us in studio is Kevin Ruto, Dr. Kevin Ruto from Tophill Hospital. Many people wondering where Tophill Hospital is at. Tophill Hospital is situated in Eldoret at Elgon View. So anytime you have, it is actually a special facility for brain and spine, but then they also have all these other services. Of course, maternity, if you'd want, they have a radiology department. If you want those investigative tests, then you may consider Tophill Hospital as one of those top priority hospitals you'd want to visit. Their tagline being extraordinary, exceptional technology, extraordinary care, meaning they believe so much in technology, they believe so much in investing in technology and care. So anytime you have a patient and you need some extraordinary care, then consider walking making your way to Tophill Hospital. You know, somebody told me don't say walking. Some of us drive to hospitals. Anyway, so with us today is Dr. Kevin Ruto. We've talked about hypertension. Currently, we are tackling diabetes. And if you have any question to ask about diabetes, remember to shoot your question. Also, very important to note is that also share this broadcast to your friends and family, because I said the most important conversation happen on the Morning Glory Show. Moving forward, Daktari, when we talk about diabetes, now we've talked about the types. Maybe, are there any known reasons or causes of diabetes at the moment?
The causes of diabetes, we've mentioned them. There is on the underlying, but we have risk factors.
Okay, exactly. That's what I mean. Like, what predisposes people to diabetes? Yeah.
Good. So, still, we have those modifiable factors and non-modifiable factors, and that is why we've labeled them as lifestyle diseases. So, the non-modifiable factors, a majority of the time, they remain constant. Sex,
family history,
age, family history, ethnicity. Okay, those are constant. If you have a family history of diabetes, there are very high chances that at some point in life you are going to get diabetes type what?
That's now type 2, right?
Type 2,
yeah.
Exactly. You are a good student.
a very attentive one for that.
Very good student, okay? So there are very high chances. It is usually hereditary in origin. Then, of course, sex, I think, just to confirm, it's also been associated with more men. Then ethnicity, still more among the Caucasians, but on this side also. It has become more prevalent. Those are some of the non-modifiable factors. And age, as you grow, diabetes has been associated. We have more of diabetes type 2 than diabetes type 1. Those are some of the risk factors. Among the non-modifiable risk factors of diabetes, they also remain almost constant. One being sedentary lifestyle, the leading sedentary lifestyle, of which now you know what sedentary lifestyle is. Another
Actually, I came across that term at a very early stage in life. Nico Form 1, but I cannot have sedentary lifestyle here. I need to bring that guy to the show.
Sedentary lifestyle. 2 is alcohol and cigarette smoking. 3, which is also a major leading cause, is what you talked about, obesity. That is why I told you hypertension and diabetes,
they're almost related.
They are almost related. And that is why you've opted to obesity. Watch your weight. I know we have people on the show. They would tell us what the normal BMI would be. Keep it 18.5 to
24.5. I told you I'm a good student.
Let's keep it there. Yeah. Obesity. Then diet, of course. Less of carbohydrates, less of sugars, less of salt. Yeah. You stand then by so doing, at times even we are not trying to really say that we prevent you from getting diabetes. What we are trying to say is that yes, because you have a family history, you might get there. But by getting there with an obese body, getting there as an alcoholic, this condition is more likely going to give you more complications that if it found you fit. So that is why we want to focus, so that if it finds you for one reason or the other, then you can easily control it.
You're prepared, quote unquote.
Yes. And the complications associated with it will be lesser. Because what diabetes does, one, and especially when you have obesity, there are fat deposits in your blood vessels. Okay? Fat deposits in your blood vessels. So they get narrowed. Once you get narrow blood vessels, then you add sugars that are not well controlled and all that. What is going to happen is chances are you can easily topple over to hypertension and you can get complications. Some of the other complications that are associated with DM, besides what you talked about initially, were now what we have the macrovasculature. Macrovascular major vessels, and then microvasculature. Micro means small vessels. So diabetes, as far as macrovasculature is concerned, has been associated with what? Stroke, cardiac disease, also being associated with what you call nephropathy. Okay? But now for microvasculature, for diabetes, it affects even up to the tiny vessels, the capillaries. So these patients might end up losing their eyesight because of what you call retinal retinopathy. So deposits of fat and all that in the retina, so they lose their vision. Number two, they get what we call nephropathy. Nephropathy is complications of the kidneys because of those compromise of the blood vessels that supply your kidneys. So they get kidney failure. So end up kidney failure, end-stage renal disease, dialysis, and death. Then besides that, they get what we call peripheral neuropathies. It gets even to the nerves. As it gets to the nerves, it causes demyelination and all that. So these patients lose sensation. They have tickling sensation on the extremities, both the upper and the lower limbs, and they lose sensation. So what they usually present with, a majority of them come with foot ulcers because their sensation is decreased, so they get ulcers. And these ulcers in diabetic patients, when your blood sugars are not well controlled, for those wounds to heal, they take really long. Okay, they get septic, and at times a majority of them we've ended up amputating. If you are to look at statistics of a majority of the patients that have ended up with amputations, I would say a majority of them are actually more of diabetic patients than even the trauma patients. Trauma patients, I mean accidents and all that. So because they are not able to feel their limbs, they get injured so easily. Diabetic feet, they get gangrene because of the blood vessels that are no longer supplying their feet. So we end up amputating them. So basically what you're saying, instead of us getting there, instead of us taking away your feet for one reason or the other, let's focus on those things that you can change, so that at least you can be able to live optimally to around maybe 100 years if God plans you together.
Okay, and then let's talk about, now that it's a very common thing all over, both hypertension and then diabetes. How much of course, expensive is it to treat? Let's talk about insurance. How do you, from where you sit, do you get many insurances willing to insure these kind of diseases, and what kind of advice would you give maybe those who are already in the mess and are actively treating either of the conditions?
Because of the prevalence of hypertension and diabetes, high number of people having them, pharmaceutical companies, so many pharmaceuticals produce so many drugs that we use to treat hypertension and diabetes. And just as they say, whenever you have more supply, then probably it balances off. So treatment of diabetes and hypertension is very cheap. Anti-diabetic medication and anti-hypertensive medications, they are very cheap. So none of the insurance companies actually is not covering. A majority of them cover for treatment of hypertension and diabetes in any hospital. Including Tophill Brain and Spine Hospital. Yes.
Okay, thank you so much. Unless there's something also you feel you've not touched on diabetes, then I would want us to move to ulcers. It's one of those I know we may need to spend some time there. So maybe just you give us your, I would say, I wouldn't want to call it closing remarks because you may end up telling us, thank you, let me next time. So maybe you say something that you may want to mention about diabetes, then we move to ulcers.
I think we've talked about a majority of the things that we are supposed to do. What I will just say is, let's work on that which you can work on. For that which you cannot work on out there, we'll come and deal with it when
it arises.
You can deal with it. But for that which we can work on, prevention is better than cure. If you can manage to prevent, just prevent. And if it gets to a point that, then we'll handle it appropriately. Then of course, I think it will be very unfair to our pregnant women, because these two diseases also, we have what you call gestational onset diabetes, what you call gestational diabetes. When you're pregnant, at times you might get sugars. And even for hypertension, okay, we have pregnancy related hypertension, what we call preeclampsia, and the worst part, eclampsia, and even HELP syndrome, which has been it's been actually causing so much mortality among women, I must say. So maybe next time when we get another chance, we can come and talk about our pregnant women and hypertension in pregnancy,
diabetes also
in pregnancy, which for the benefit of our mothers who and also for the benefit of love, So it's
okay. Daktari mentioning love almost 10 times on this particular show tells you something. You need to visit Tophill Hospital. It seems there is some love blossoming around there. Somebody told me it's only the veterinary officers who get a chance to eat their clients. Anyway, moving on to ulcers, Daktari. Somebody here called Joshua Kiptolele says he's following from Cabenes, Kenya. There's also Kipleitich Mabwai saying good information. Thanks. Rema Nehema seated in the studio says so educative. Thank you so much. Let's now move on to ulcers. Of course, I wrote that from my knowledge as a journalist. Somebody told me, what exactly are you going to talk about here? And I was like, okay, Doctor, will just fix it up. What I actually intend to talk about is the issues that come. We've even talked about ulcers, Migu and all that, but I'm talking about the one that is related with acidity and all that. Yeah, somebody told me, make sure you tell that because you gave him a very wide one. Did I? Really? Or you understood me with the wisdom of a doctor? So a colleague of yours told me, see, hapo ungemspecify that, I was like, he'll figure it out. Yeah. Okay. So when you talk about ulcers, what exactly are we talking about, actually? What is ulcers?
Yes. Whoever told you that must be a good medic. Because ulcers, basically an ulcer is, I would say, it's any wound. It's any breakage in an epithelial lining. An epithelial lining, I mean, any barrier, skin, mucosa and all that. That is why I was even talking about venous ulcers and all that. So it's just a wound on an epithelial surface. Okay. So ulcers you can have ulcers anywhere. You can have oral ulcers, an ulcer in your mouth, okay, on your limbs, your stomach and all that. But then the most common thing is what you call gastric ulcers and duodenal ulcers. Which other people you've had, majority of them, we call it peptic ulcers, peptic ulcer disease. This is ulceration in your stomach lining and your duodenal lining, okay? So these ulcerations usually, because they are wounds, of course they have a cause, okay? or which the major cause of ulcers is one, we have a culprit, a bacteria called H. pylori. You must have heard about that term before.
I think I've ever dealt with a certain kit.
Yes.
I was given at your place, a
for
huge
2
one.
weeks.
Yeah.
So it's called Helicobacter pylorus. Helicobacter pylorus is a very notorious bacteria that resides in your intestine, in your stomach and your duodenum, and it tends to feed. Let me say, to feed. Actually, what it does is not feed literally. What it does, it breaks down the food that you eat. Okay, as it breaks down the food that you eat, it produces some acidic medium, ammonia. So this ammonia raises your pH, and once you have a very high acidic medium, it digests the stomach lining. The stomach lining has a mucous membrane. A mucous membrane is a lining of mucus before you get even down to the
flesh,
to the lining.
if I may call it flesh, right?
Yeah, it's a lining. It's a line. So once it secretes this acidic medium, the region around there now corrodes. So you lose that lining, and as it goes down to the mucosa, it also eats that mucosa and the lining. So it causes ulceration, okay, because of what it does. So that is a major contributor. That is why we put you on the kit, okay? You need to watch the food that you eat. You must be eating so much of
it was long time ago, I think. You said I must be eating too much of
roadside.
Okay, actually we had because exactly maybe we need to even talk about that now that you said it is a stubborn one. What exactly causes issues with H. pylori? Yeah, because what I was given was called an H. pylori kit. Yeah.
So what really causes? It's a bacteria. So it means it's transmissible from one person to the other. Okay. And the only way we transmit one thing that is in the GI tract from one person to the other is through contamination. Okay? It's through
so that means maybe there was some siwa ilikuwa inatembea mahali na mama wa chipo alikuwa anapika chipo yake and things happen.
And how we handle, of course, eat by the roadside. I come with my 100 shillings, I give it to mama. She takes it. Okay? To another, money moves, so then you take it. So that is, and of course at times we just take things because they look good. Umepata some
smoky guys, man.
Guys, umepata, what do you call, there's this mutura. They say not to be sounding, but they say when you find a clean mutura guy, he's suspicious. That's suspicious.
That's suspicious with raga.
So the standard for it's like finding you eating mutura during the day. That's suspicious. You
have to eat it kwa giza kidogo.
Na kwa giza.
Those are ingredients actually.
They are good. They are good.
But then they may end up causing problems.
They end up causing problems. So that is the major cause of peptic ulcer disease. Actually, the peptic ulcer disease is a combination of gastric ulcers, I mean stomach and the duodenum. Okay, so that is the major cause of those. But then other causes include the standard cause of a majority of our problems: alcohol, shots of gin, 40%, shots of whiskey. You intentionally work on corroding your own stomach lining. You do it very intentionally. So by the end of the day, you corrode, you get ulcers, which is a majority of the nini. So you get chronic gastritis. Gastritis is just ulcerations on your stomach lining because of what you are taking in, corrosive substances. You are taking in spirits. So you come there, we tell you stop this, but still, it's life. So those are some of the causes. How do they present? Okay, for H. pylori, active peptic ulcer disease, a majority of them, it presents with one, bloating. You eat anything kidogo, then you feel so much bloated and gassy. Okay, because of the ammonia that is secreted by this bacteria. Then loss of appetite. You are not feeling so much because of that. Then of course this belching, you belch a lot, very foul smell. Now another thing, of course, pain. It's an ulcer, so it's painful. So the what you call epigastric pain. So a majority of these patients usually tell you they feel so much pain around it. Okay, which at times even they might confuse, and even cough for those patients who have a gastric reflux disease because of the hyperacidity. So they reflux a lot of acid, so they end up with cough. So those are some of the symptoms of ulcers. Ulcers. Yes.
And maybe apart from H. pylori, then maybe what are the other causative agents? And before it becomes ulcers, because there's also this confusion between acidity and ulcers itself. Maybe what other forms of acidity causes ulcers in the stomach, and what are the causes of those acidities apart from H. pylori?
Acidity. Okay. So even as I mentioned H. pylori by itself is not a direct cause, but what it does, it causes hyperacidity. Because it produces ammonia. Ammonia is acidic, okay, which corrodes. Other things that cause acidity is the alcohol is acidic. It corrodes. Then corrosive substances. There are so many corrosive substances that we take. Then of course we have those drugs which I haven't mentioned. Things like diclofenac, what you call NSAIDs, ibuprofen. They are also a major cause of hyperacidity. They are corrosive in nature. That is why a majority of the patients, when they come, we first ask them, do you have any problem with what? With hyperacidity. So that we do not prescribe a medication like diclofenac for a patient who does what? Who has
hyperacidity.
Hyperacidity. Okay. Then other causes as to the cause of course we have those foods that are acidic in nature. Okay. But a majority of the times we have just intrinsic hyperacidity. For someone who has hyperacidity, does not necessarily mean that they have what?
Ulcers.
They have ulcers. An ulcer is a complication of hyperacidity. So at times you can have hyperacidity, like you take something like beans. These red beans. I think it's now getting off, and kales. Kales is sukuma wiki. Acidic foods. Then you feel bloated and all that. You have hyperacidity and not what?
Ulcers.
Not ulcers. But by the time we get to an ulcers, then it means that already you are getting complications of what? Hyperacidity. Yes.
And maybe what now let's look at you talked about the causative agents of hyperacidity and all that, and I've seen people also relate ulcers and hyperacidity to stress. Is it something that exists, and how does that happen?
Yeah, it does exist. There's a component of stress that gives. Number one, when you're stressed, you do not take so much of food. Yeah? Then when you're also stressed, the stomach tends to secrete so much of acid, what we call the peptic acid. So it gives you this burning sensation because you do not have enough food and you're secreting acid. Ideally, what needs to happen when there is no food, your stomach, you're not supposed to be secreting so much acid because this acid has nothing to digest. So once you have nothing in your stomach, you're stressed and all that, and you're secreting so much acid, it gives you hyperacidity, which can lead to ulceration. Okay, but the major cause of ulceration is not stress. Stress by itself does not give you ulcers. Okay. Then of course there are those other things, sinister things that are very bad that we need to watch out for. Malignancies, cancers of the stomach, which at times can cause also corrosion. Yes, hyperacidity. Yes.
You've talked about when talking about hypertension and diabetes, we talked about things that we can control and those that we cannot control. With ulcers, are there things that we cannot control in terms of maybe genes and all that? I've heard people talk about it being hereditary and all that. Is it a myth or it's something that exists?
A majority of the ulcers actually we can be able to control. And actually, unlike hypertension and diabetes, which is treatable but not curable, ulcers are what? Ulcers are curable. Okay. You remember the other time we talked about treatable and curable. An ulcer is it's a breakage, so we can cure it. We can work on the acidity. we can lower it because you have drugs. And once you lower the acidity, then the wound gets time to heal, so it heals. Once we've dealt with the H. pylori by giving medication, you've finished your kit, we do our testing, we still find it, we give you another kit, and we've dealt with it, then the ulcer gets time to do what? To heal. Okay. At times for those malignant ulcers are those ulcers that are very nini. We can do what we call both endoscopy. So for endoscopy, you have what we call therapeutic endoscopy as far as diagnostic. Diagnostic is I go in with a scope. I look at the ulcers, those that are very bad in nature, then I burn them. I do what you call cauterization. So once you burn them, you obliterate them. So you make it heal so nicely. So ulcers we can work, and of course we work on the stress and all that. I avoid medications that can give you the same. So I give you time to heal. So ulcers basically, and complications of ulcers are not as bad, not as fatal as those that we talked about, stroke and all that, because the only major complication of ulcer is what? Is perforation. Perforation is this ulcer was not attended to, and so there has been continuous corrosion of the stomach lining, and now you've perforated the stomach. So you'll be leaking contents of the stomach or of the duodenum into your peritoneum, which can cause further damage. There is a major nini, and by that it causes peritonitis. That is an emergency. An emergency, those are patients who will walk into your hospital now, and if you do not do anything within the next 24 hours, they are dead. Okay? They are dead because of septicemia, peritonitis and all that. Then they go into septic shock and they die. So there is an emergency that whenever you are called in, probably if I was sleeping and I'm called in at the middle of the night too, I'm told I have a patient with a perforated disc presenting like this, you do not think. If you are in the middle of a very serious activity, you just stop it there. Okay? Yeah. Whatever it is, serious activity.
Anyway, that gets me off. Imenipata kama nimezubaa kidogo, so sina kitu ya kukuambia. Anyway, you tuned into the Morning Glory Show. A friend of mine called Cosmas asking if Daktari has a clinic. I'll be repeating this again, that if you would want to talk to Dr. Kevin Ruto, then you can make your way to Tophill Hospital. Tophill Hospital is situated next to Bomain. Next to Bomain, I think that's basically it. So once you are at around Bomain there, you can actually be able to spot Tophill Hospital. If you ask anyone, then they'll be able to show it to you. I usually give directions to Tophill Hospital. I can tell you that it's one of those most accessible places because you can access it from the Nairobi Road, the old Nairobi Road on the other side. Maybe those are for those who are coming from Kisumu, I would say Eldoret Kisumu Road, then around Nairobi Road there, you'd see a signpost. It's I think 1.8 kilometers to Tophill Hospital. But then I think the oldest landmark around there is Bomain. Yeah, so you can also make your way through the temple around Etiaret there. I think it's just a matter of around 800 meters. You'd be there. If somebody is coming from Nairobi, then still they would want to use the Nairobi Road, I think. You'd see a junction there with the signpost showing Tophill Hospital. Still, they have a number. I think I need to have it. I need to master it. I don't know if you have it offered. But then at the end of this broadcast, I'll be able to give you the contacts to Tophill Hospital, because so many people asking if Daktari has a clinic in town. I don't want to say no directly. Maybe you have one, so you'd clarify that. But then what I'm sure of is that you can find Daktari at Tophill Hospital anytime you need him. And then of course, also when you reach there, there are other doctors, they have other consultants and all that. They have other departments. I've told you there is a physiotherapy department, a radiology department. So be sure to get some extraordinary care. Okay, hope I put that right. So moving forward, we've talked about hypertension, we've talked about diabetes, and we're just finishing up with ulcers. And I was talking about the issue of it being hereditary. Is there such a fact as maybe hyperacidity being hereditary, and at the end of it all causing ulcers? Because unasikianga mtu mama yangu alikuwa nayo, so pia mimi niko na. Is it something that stands water, holds any water?
There's some aspect there's some aspect of heredity. There's some aspect of heredity, but unlike the other two conditions that we talked about, whenever you're looking at heredity or transmission from one generation to the other, you look at the linkage, how much of genes are associated with this kind of disease. As far as ulcers are concerned, the linkage is not as tight as that. If you still remember chemistry a bit, there used to be van der Waals versus ionic covalent bonds, which were really strong. Then as you come to these other bonds, they were just light. So the linkage is very...
It's not as strong as
not
it
as
is.
strong as those other hereditary diseases.
Then the other question I don't forget here, because he mekuja inbox, somebody is asking the relationship between reddening of the lips and stomach ulcers or acidity. Is there any relationship?
Good. Thank you for reminding me that I thought of talking something. So besides peptic ulcer disease, we have something called gastroesophageal reflux disease. Gastro is stomach. Esophageal is the esophagus. Then reflux is regurgitation disease. Okay. Gastroesophageal reflux disease. Okay. Which we usually, of course, the presentation is almost similar to peptic ulcer disease. But usually for this, what now happens is you have an incompetent valve. Okay. There is a valve that is created by the diaphragm at the junction between your esophagus and your stomach. There is a valve that retains your food in your stomach. Okay. So when there is an incompetence of that valve for one reason or the other, okay, maybe age or maybe what you call hiatus hernia. Hiatus hernia is an outpoaching of the part of the stomach into the esophagus. So it gives you an incompetent valve that, so you might not be able to retain contents of your stomach your stomach contents in there because of that incompatibility. So when that happens, therefore, the stomach by itself has so much acid. The pH of the stomach is 2. Do you know what other acidic component has a pH of 2?
That should be hydrochloric acid.
Hydrochloric acid.
Yeah.
Yes.
See, I'm a good student.
And actually, what the acid that we have in the stomach is hydrochloric acid. You just burn. So it is only that the stomach has
good lining.
Yes, a mechanism, a barrier that is able to maintain that kind of pH. The rest of the GIT coming upwards to the esophagus and going downwards past the duodenum does not have an equally good pH. That is why by the time you are secreting things from your stomach going downwards, number one thing that needs to do, just from your biology in high school, is that it needs to be neutralized to increase the pH. By what? What does that?
When you increase the pH, then it becomes basic.
It becomes basic.
Yeah.
And what component does that?
It should be a base.
Yes. From where? You have some bile acids. You are good in biology. So it has to be neutralized so that it does not cause more damages So when you have that incompetence and your stomach contents now reflux to your esophagus. Okay. What is reflux? Reflux, I think you call
kurejea.
Yeah, kurejea. Okay. So when you have that incompetence, you'll be refluxing. You eat so much, you go sleep, then so it causes you corrosion. Then for those cases of severe gastroesophageal reflux disease, they end up even with what? Corrosion of the teeth. Okay.
Teeth.
It corrodes the enamel. For severe disease, it corrodes the enamel all the way. Then it causes even the reddening of lips and all that because of gastroesophageal reflux disease. So what we usually do for that, number one, we focus on lowering the pH. We give you medications that do that. Then we also try and look at what is causing this gastroesophageal reflux disease. There are some surgical procedures that we do in case you have severe forms of gastroesophageal reflux disease, especially for hiatus hernia and all that, we can go and twist it at an angle so that we tighten it so that
it doesn't reflux.
It doesn't reflux. Okay, we do what we call fundoplication, Nissen's fundoplication, and other procedures that we do, technical procedures. Yes.
Okay, thank you so much for making time to be on the Morning Glory Show. Of course, we're coming to almost the tail part of this particular interview. I'll be going back to Daktari unless once again there's something maybe you feel you've not touched upon when it comes to ulcers and the reflux disease that you've mentioned. Maybe then I would give you a chance to give your closing remarks about today's discussion.
If there's something I haven't touched, one thing I didn't stress on is that the major cause of gastric ulceration, that before that, ulcers in the elderly, okay, ulcers in the elderly above 65 are sinister. You remember what I said about hypertension in the young? I look at it from a different angle.
Yeah.
So ulcers, GI ulcers in the elderly above 65, we also look at it from a different angle, because there have been a majority of them have been associated with what? Stomach cancers. So it is just not enough. And even how they present, a majority of them will present with what? Anemia, because those ulcers with the malignancy, they just bleed pole, so they present with anemia, darkening of stool. So these patients present with anemia of a known cause, but when we investigate further, you notice that they have ulcers. A majority of them usually are associated with what? Malignancy. So we always want to be much more thorough than in the eye. And how are we thorough as far as that is concerned? We usually need to do an endoscope. We usually want to go in literally
and look at the stomach.
And not only look, we need to take a biopsy. So we go in, we take a small biopsy of the ulcers so that it goes to the lab, so that it enables us to make a very early diagnosis and give an early intervention. So any patients above 65, we advocate for endoscopy plus biopsy of those ulcers so that we are able to catch those cancers at a very early age. Okay, so we get to know, is it ulcers that we are dealing with, or we could also be dealing with cancer, which is common at that age group. That is number one. Then maybe another thing I forgot to mention: anti-diabetic medication, anti-hypertensive medication, and anti-cancer medications. Their side effects are very minimal. A majority of the patients tend to refuse, tend to not to want to be on these medications for long. But we say, whenever we've diagnosed you with hypertension, with diabetes, and ulcers that haven't healed, their medications usually go for a lifetime. That is one. But number two good thing about this is that there are side effects, and as far as even shortening your life is concerned, they are very minimal. Okay, so they are insignificant actually. So it would be good. And wherever you get side effects for one medications, we always have alternatives. We do not have just specific. We always have alternatives that are fit for you as a person, so that it becomes just a habit, and you just take your medications and you can be okay just like any other person. And of course, there are things that we can say, a lot of things, complications of diabetes, which are life-threatening, like diabetes ketoacidosis, which causes death. But those are complicated. They need more time so that we can shed more light on it. Basically, what I'm just trying to say, whenever we diagnose you with this, adherence to medications is key. Adherence to medication is key for us to avert complications associated with the same. Yes, that is my parting shot actually. Adherence to medication is key to avert complications.
Okay, maybe you just need to take your parting shot looking at this camera then.
All right, so thank you once again for the session. Healthy, wealthy wise. I am very sure at this point we are much more educated, we are much more wise than we came. So There are lifestyle diseases. There are things we can modify. Let's work on those that we can modify. And for those patients who we've diagnosed with the same, just as I said to you, these are very manageable conditions, which whenever we adhere to medications, whenever you follow just the simple instructions given by medical personnel, then you can be able to live optimally, and the outcome are usually very good. So to avoid complications, adherence to medication is key.
Okay. To avoid complication, adherence to medication is key. That is Dr. Kevin Ruto from Tophill Hospital giving a very powerful parting shot there. We've been talking about hypertension, we've talked about ulcers, we've talked about diabetes. And as I promised, this show will run in the evening. But then before we even rerun it, it remains on the broadcast. So anytime you need to confirm something, maybe there's something Daktari said and you are not so attentive, the goodness is that it's recorded and remains there. So anytime you need to rewatch it or you need to confirm something, then you can also watch that. I promise to give you the number to Tophill Hospital, the number that Tophill Hospital uses, and it is quite a simple one: 0782 12 12 14. 0782 12 12 14. Okay, hope my pronunciation of the numbers is fine, so that somebody doesn't call another place. So that's the number to Tophill Hospital. Make sure that anytime you have a patient who needs extraordinary care, then you consider taking them to Tophill Hospital. It is a brain and spine facility, but then beyond that, it is a level 5 hospital, means that you can get all these other services, including investigative procedures, that is MRI and all that, MRI, CT scan, there is ultrasound and all that. Then you can find them at Tophill Hospital. They also have a very good physiotherapy department. We had the physiotherapists come to the show the other day to also shed some light about what happens in that department. We have a very nice radiology department and all those other maternity wing, I think. Most of the people watching us right now are young people. So if you need a good, so consider walking into Tophill Hospital. This has been coming live from Dawi Afrique Photography. Of course, Dawi Afrique Photography is the best production house. Daktari can confirm that. Nile tu kamera imetoka kwake, but then it is the best studio in town, the best studio in the region. If you need good experience in front of the camera, consider working with Dawi Afrique Photography. Then also, together with very nice media, Dawi Afrique Photography will be coming into the street. We'll be coming into the streets to cover those stories of yours. So we are now introducing news. So we would say that we're giving a new dimension and perspective into news. So you'd be seeing more of us, and you'd see more of us in the street, so we'll be coming there. Nonetheless, this has been the Healthy, Wealthy, Wise edition of the Morning Glory Show. My name is MC Kalia, and until tomorrow, see you.